Can y'all hear me now, though? Sweet. Okay. All right. So tonight we're going over bleeding. We're going to look at this from a physiological standpoint. It's not. It ultimately boils down in your job to just making sure that the wet stuff stays. The blood stays inside the veins and it doesn't leak out. That's our primary goal. Is if we spring a leak, we stop the leak. But there's a little bit more to that, especially when we're dealing with internal bleeding, because it's not always easy to deal with. And also understanding that sometimes it's not as easy as just putting a bandage on somebody, right? Especially when they're having massive bleeds. If they've been bleeding profusely for a while before we get there, then we have to deal with other issues and this kind of stuff. So we're going to go a little bit more in depth than what you may have done in EMR or if you've taken another first aid class in the past. But I mean, that's part of being the EMT is you're the higher trained. You're supposed to know more of what's going on and kind of head that stuff off before it gets to that point. So after managing the airway and recognizing bleeding, think back to your assessments, right? We do our scene size up, then our primary, which is ABC. After making sure that we have our airway and our breathing taken care of, it's important for you to understand how their bleeding or even just circulation in general can affect the body. Bleeding can be external and obvious, very, very obvious, or it could be internal and hidden. And it can be obvious bleeding without that big of an injury. When you think about certain areas of the body, like the face, extremely vascular. It could be just a paper cut, and they're going to look like they're in a horror movie. They're going to be blood everywhere, and sometimes it's just hard to stop it. Either type of bleeding is potentially dangerous and can cause weakness, shock, and death. Uncontrolled bleeding is the most common cause of shock, following a traumatic injury. So the reason that everybody goes with hypovolemic shock being like the go-to thought when you think of shock is because it is the most common. The fastest way to get into shock is to lose your blood supply. For the anatomy review, think about it. We have a closed circuit circulatory system. You have your heart that pumps, and you have your veins, your arteries, and your arterioles, capillaries, all that stuff. But everything's a closed system. At no point does blood leave those vessels by design. If you're seeing blood anywhere outside of a vein or an artery, it's not supposed to be there. So they're bleeding out. If they're bleeding internally, any of that stuff, any signs of like bruising, that's blood that's escaped its tracks, and it's not supposed to be there. And blood is an irritant. So when somebody actually has bleeding either in their brain, in their skull, in a different part of the body, it hurts. It doesn't feel good. So if you're wondering if they are going to be, that's a sign. Actually, it's more of a symptom. If they are bleeding internally, they're going to have a lot of pain associated with that because every organ, every body tissue that the blood touches, it hurts. The cardiovascular system that circulates blood to all the body cells and tissues. This delivers oxygen and nutrients, and it carries metabolic waste products away, which is mostly CO2. This is responsible for supplying and maintaining adequate blood flow. Your components are going to be your heart, your container, which is the actual blood vessels, your arteries and veins, and then the fluid itself, which is your blood. For your heart needs a rich and well-distributed blood supply that uses its own coronary artery system to do that. Whenever the coronary artery system doesn't work properly, the heart doesn't get the oxygen it needs, and that is what we call a heart attack. Heart attack is kind of a blanket term, and we've already gone over that chapter of cardiology. So if you guys have any questions on that, just remember that. Even if the blood vessels are not a problem, if we chop off our hand or our foot and we start bleeding out heavily, the coronary arteries may not be the problem. The problem may just be that there's no blood in them. And then you start to have problems with the heart. And that's going to come into play later on in this chapter when we start talking about hypovolemic shock. But your heart works in two paired pumps. You have your upper chamber, which is your atria, and your lower chamber, which is your ventricles. That's why you hear that double beat every time you listen to a heart, that ba-dump sound. The first one is your atria, pushing blood into the ventricles. The second one is your ventricles pushing blood out of the heart, either to the lungs or to the rest of the body. And then it says here, blood leaves each chamber through a one-way valve. Remember your tricuspid and bicuspid valves, but those valves are present all over the body. They help the blood flow defy gravity, whether you're laying down, standing up, jumping, flying in a plane, jumping off a building, any of that stuff. Those blood vessel one-way valves, they're located every so often all through your circulatory system to make sure that the blood doesn't, the gravity doesn't, and the weight of the blood doesn't pull back too far. Um, those those valves are really useful. Those valves are also a pain in the ass whenever we're talking about putting in IVs, especially if you're going to go into somebody's hand. All right. So here's two pictures of your heart, just to kind of review. As you can see, from your point of view, you can look at the blood flow going through the heart from left to right. But just remember that these pictures are the patient's left and right. So when we talk about it, we say that everything enters through the right atria and the right ventricle first. For the heart of your patient, absolutely. From your point of view, it's left to right. But you have your superior and inferior vena cava. Those are your two great veins that dump blood into the heart. And then you have your four chambers. When blood gets out of the heart, it's going to go through the aorta and then out to the body from there. The actual path of your vessels, you have your arteries first. They're your main ones. So you start with the aorta, then it goes out to like your radial artery, your femoral arteries, carotid arteries, so on and so on. Those arteries break down into arterioles. There's no real difference in them other than they're just smaller. There's a little bit less pressure, but they're working their way down toward the capillary bed. The capillaries encircle all cells of the body because that's where the gas exchange happens. That's where the oxygen leaves the blood, goes into the cell. The cell picks up the carbon dioxide and then carries it away back toward the lungs. So from the capillaries, now you're working your way back to the heart with waste. So you're going to go from small to large, capillaries to venules to veins, and then back to the heart. And then it just keeps repeating the process. For your blood, we have a couple different types. We mostly only concern ourselves in EMS with red blood cells, but when any of these others are out of whack, sometimes that's going to present in your patient in different ways, so you'll kind of know. Your red blood cells are responsible for transportation of oxygen to the cells and carbon dioxide away from the cells. And they use that by having hemoglobin in them. So red blood cells, even though they're cells, if you guys have been in a biology class in the past or whatever, blood cells don't actually have a nucleus. There's no nucleus in a red blood cell. There's hemoglobin in the red blood cell. So as it's passing over the capillaries, it's almost like a magnet. It just picks up the oxygen or it picks up the carbon dioxide, depending on where it's at in the body. You have your platelets, which are responsible for forming blood clots. Your white blood cells are responsible for fighting infection. And then your plasma. And your plasma is the liquid part of your blood. That is the actual connective, you can call it connective tissue. You have plasma all over. Your bones have plasma. It's just a different consistency. It's solid. But in blood, it's going to be a liquid. That is what keeps all the cells, your red blood cells, your white blood cells, your platelets, all that stuff is held together in the plasma. And it is mostly water. So if a patient were to dehydrate severely, eventually that plasma is going to start to thicken because they're losing their water. Blood clot formation depends on several factors. We have blood stasis, which means it is going to stop moving. Anytime blood stops moving, it starts to clot. If you think back to your cardiology chapter, we talked about a couple of different issues that people may have, like atrial fibrillation. People live with AFib. That's not something they have to fix it. Oh my God, you're going to die. That's not one of those heart issues. However, one of your main risks of AFib is that the blood's going to start to pool in the atria because it's not pumping properly. And then it starts to clot. Those clots have to go somewhere. So you're going to either have an embolus, a stroke, that kind of thing, depending on which atria it develops in. That is called blood stasis. That's what those clot formations are dependent on. And in those patients, they usually take something like either a blood thinner or aspirin, that kind of stuff. But just know that anytime blood stops moving, it will start to coagulate. If there's a change in the blood vessel walls, like a wound, then you're going to start to lose blood there, and the body will naturally start trying to clot there because it's trying to close that hole up. And then you have the blood's ability to clot, which is usually affected by a disease or medication, depending on what they're taking, or if they have like a free bleeding disease or something of that sort. Um, for your autonomous nervous system, this is the part of the nervous system that we can't control. This monitors your body's needs from moment to moment, and it's usually pretty quick. If it decides that you need to up your blood pressure, it's going to do it pretty quickly. It adjusts blood flow by constricting or dilating blood vessels, automatically redirects blood away from other organs to the heart of the brain. If you start to lose blood, the body's going to start making decisions like your fingertips don't really need a blood supply. Your GI tract doesn't necessarily need a blood supply. In fact, that organ goes the longest without blood without having any issues. But your heart, your brain, your filtration system, like your kidneys, all of that is pretty critical to your survival. So when you either lose blood or if you're too cold, those sort of things, your autonomic nervous system will adjust your vessels to where you can actually function with those organs. Give me just a second, guys. All right, guys, I'm sorry about that. So getting back on it, let me see. Your nervous system adapts to changing conditions in the body to maintain homeostasis. That's the goal, right? And perfusion. If you don't have perfusion, or if your perfusion is low, like hypoperfusion, that is what we call shock. That's what we're trying to avoid. Your body does it automatically, but when something goes wrong, say you're in a bad accident, your body's not necessarily able to do that on its own. So it's up to us to try to help it along, help it maintain that as long as we can. If the system fails to provide sufficient circulation for every body part to perform its function, then shock results. And in this case, if we're talking about trauma, we're typically talking about hypovolemia because we bled out. But any disruption, we talk about septic shock, anaphylactic shock, they're all kind of the same thing. Let's see, just wondering if my book is the only one that goes from page 882 to. Anybody else having that problem? If that's a widespread thing, I'll reach out to the publisher and see what's up with that. Does your page jump back, Corey? Does it go 931 and then maybe back to 883 or something? Hmm. All right, I'm gonna keep going. Yours doesn't. All right, it may just be your book. That's weird. If you see any other issues, that's a lot of pages too, 50 pages. Hmm. Corey, I'm gonna reach out to the publisher about yours, see what they can do. They may send you another book. That way you've got, because that's the bulk of the chapter. Doesn't go back, it goes straight to chapter 26. All right, yeah, I'll reach out to the publisher for that, figure out what's going on. They may be able to send you a new book. So for your pathophysiology and perfusion, perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. In accurate amounts, um, um, no, I'm sorry, adequate, not accurate. Adequate amounts depends on what you're doing. So if you're sitting on the couch watching YouTube, you really don't need that much blood flow. But if you decide to get up and run a 5K, you're going to need more, right? Your oxygen demand goes up, so you need more of a pulse, more maybe more blood pressure, that kind of thing, just to maintain that oxygen demand that your body needs. And also, as you breathe faster, or as your cells start working harder, you're going to start to build up more carbon dioxide. So you're going to breathe faster, not just to get your O2 in, but also to get that CO2 out. So your body's going to, first of all, it's going to start with a higher pulse. It's usually the first thing that happens. So when you need more oxygen demand, or when your oxygen demand goes up, your pulse is going to go up first. This must be fast enough to maintain adequate circulation throughout the body and to avoid clotting. Can anybody think of a situation where somebody may need a higher pulse, but for whatever reason they're unable to get it? Maybe a medication or something of that sort. Is there anything you can think of that would basically, I was saying, is there anything you could think of where that would stop a patient from getting a higher pulse if they, even though they needed it? Dig, dig screws everything up. That's a paramedic's nightmare. Yeah, so Dig is one. Um, Labetalol is another one. Any of your beta blockers that stop the pulse from climbing, stop the heart from doing too much work, um, that can be a problem. Because if you're, let's say you have a patient that takes beta blockers and they get into a traumatic injury, a car wreck or something, they start losing blood. Well, if they lose blood, they're losing transport cells. So the blood that is circulating doesn't carry as much oxygen. Even though they're just sitting there, it's not enough to support their life because they've lost a lot of their carriers. So the body's response to that should be, we're going to pick up the pulse. But the medicine is stopping them. The body can't pick up the pulse because they're taking a beta blocker. So that's one of the issues where you may run into this. If there's an elderly patient or somebody that's a heart patient is in a wreck, they've lost blood, it's very, very important. It's very important in general, but when you're dealing with that, it's a lot more important to stop the bleeding much faster because they are not going to be able to compensate in their shock because that medicine is stopping them. And then they're going to decompensate faster. And once they go down that road, we really can't take them, we can't bring them back. The best thing we can do as EMTs is get ahead of it and stop it before that happens. And if that's the bad day that you're having, a lot of times the best thing you can do is get a paramedic out there as fast as possible if you don't already have one with you, because sometimes they can give fluids that will help bring the pressure back up, that kind of thing. It doesn't really help for their O2 sats, but it helps them maintain their pressure. It causes the heart to not feel like it needs to beat quite as hard or fast. Some tissues need a constant supply of blood, while others can survive with very little. Again, we talk about the GI tract not really needing that much stuff. All organs and organ systems of the human body depend on adequate perfusion to function properly. Even your GI tract, everything about you. If you don't have good perfusion to get the oxygen to the cells, they're going to die. Some organs can't tolerate interruption of blood supply for even a few minutes without sustaining damage. Some can go a little while. Emergency medical care is designed to support adequate perfusion until the patient arrives at the hospital. So our goal is to stop, and if we get there and they're still bleeding, our goal is step one, stop the bleed. Step two, try to maintain their blood pressure as best we can. And that's how, when we talk about treating for shock, we're basically trying to do and help the body to do whatever it needs to. We keep the blood in the system as best we can, keep them warm. The more blood they lose, the more they're going to shunt it to their core, which means the harder time they're going to have staying warm because they're not getting blood out to their extremities and stuff like that. So we'll cover our patients, put them in a position where their heart doesn't have to work as hard. So we'll lay them flat if we can, so that the heart's not having to beat against gravity. It can just beat and the blood move left and right rather than up and down. The heart requires a constant supply of blood. If something goes wrong, either the coronary arteries get blocked or you just lose the blood, um, the heart's going to start to suffer very quickly. And the problem is once those cells start to die, it can be pretty. You're not really going to get them back. The brain and spinal cord may last 4 to 6 minutes without perfusion. The lungs can last 15 to 20 minutes. Kidneys survive about 45 minutes. Skeletal muscles about 2 to 3 hours. The GI tract can tolerate slightly longer periods. They don't even really give you a number for that. And the times are based on a normal body temperature. Colder temperatures will lengthen survival times. If you've been in any kind of CPR class, or Donna, those of you that have been through advanced classes as well in the past, like your ACLS classes, They always talk about targeted temperature management, where basically you just put your patient into a state of controlled hypothermia. That's why. Is because for however long they were in cardiac arrest, those organs weren't getting oxygen. Even if you're doing good CPR, you're still not going to deliver the best amount of oxygen. Um, so the minute we get ROSC, which is return of spontaneous circulation, a lot of times in some agencies you'll see where they start trying to do targeted temperature management. And that's not something we can do at the EMT level. That's at least a paramedic, preferably in a hospital. Um, but just be aware of that. If you see them starting to hook up IVs and push cold fluid, or throwing ice packs at you or something like that, that's what they're doing. Is they're trying to cool the body down to slow down the damage from all that time without any oxygen. For your external bleeding, hemorrhage means bleeding, but it's massive, massive bleeding. Um, External bleeding is a visible hemorrhage. So if somebody loses a hand and it shoots out, that's a hemorrhage. This right here says that nosebleed is an example of a hemorrhage. I would disagree with that because you're not going to die from a nosebleed. And that, words matter, because when you're doing your assessment, we tell you to fix hemorrhages first. And we're referring to if they lost an arm and they're bleeding out an artery or something. That's what we mean. I don't want you to go straight to somebody's nosebleed because that's technically a hemorrhage. So a nosebleed would be an external bleed, but I wouldn't call it a hemorrhage. Significance of external bleeding: with serious external bleeding, it may be difficult to tell the amount of blood loss. So we can lose roughly 2.5 to 3 liters, I believe, of blood before we're at risk of dying from it. But especially when they're bleeding out on concrete, for example, and it doesn't soak, it just keeps running out. That's a massive pool of blood. But keep that in mind. If they're bleeding in the grass, you may look at the ground and be like, well, it doesn't look like there's that much blood, but it all soaked down rather than out. Blood will look different on different surfaces, whether it's absorbed in clothing or diluted in water. It's important to estimate the amount of blood loss. And like I said, good luck with that, because depending on what surface they're on, that can be pretty hard. Treatment should be based on the patient's presentation and the mechanism of injury. The body will not tolerate an acute blood loss of greater than 20%, or about 2 pints. And that's I will say that's within a time frame. But really and truly, if you're going to lose 20% of your blood volume, it really doesn't matter how long it takes. That's 20% of your blood volume that's gone. Usually, if it's a slow bleed, your body will replace it as it's going. But if you're actually hemorrhaging out actively, your body can't compensate for that. So our goal is to stop it from getting worse. Changes in vital signs may occur with significant blood loss, and this is where we start talking about compensated shock. So, first of all, let's think about this. If you are sitting there perfectly fine, no injuries, and you're not losing any blood for any reason, your blood pressure sits at, we'll say, 120 over 80. All right, and you have a pulse of about 60, and those numbers are enough to keep good oxygen and carbon dioxide swapping out at your cellular level. Now, let's say something happens and you accidentally chop off your foot. Besides the pain, you're going to lose a lot of blood from that. So now your volume is going down. What do you think your blood pressure is going to do with a hole in the system before any compensation? Blood pressure is going to drop, right? So the body's fastest buffer to bring pressure back up to normal is to raise the pulse. So as you're losing blood and you're losing blood pressure, the body's going to start to beat harder. The heart's going to work harder, move more blood, push more blood through the system. It's going to start trying to raise your blood pressure. At the same time, your vessels are going to start to constrict down, to try again. You're trying to maintain that blood pressure, because that's what the body's watching the most. All of your heart rate, your vessels diameters, and all that all serves to maintain the good blood pressure. So here's what's going to wind up happening. If you think about how your blood pressure is actually, what those numbers mean. We say we are at 120 over 80. That's normal. When you lose blood from the system, take the heartbeat out of it for a minute. If you just have a 2.5-inch hose line, if you're a firefighter, or imagine your garden hose or whatever is full of water and there's all that pressure on it, and then you lose some of it. the hose doesn't change at that particular point. You just lost pressure, so now your hose is much more squishy. You can't really push blood through. You can't push water through until you put more in the system. Um, that pressure that's on those lines at all times, that's your diastolic blood pressure, right? That's that bottom number. So if I'm 120/80 and I lose blood, that bottom number is going to drop. So I'm going to be at 120/70, 120/60, that kind of thing. Then the body is like, wait a minute, this isn't right. So pulse picks up. So you have your vital signs, you may see their blood pressure start to widen at the beginning. They're going to have a faster pulse, and it's all to maintain that 120, trying to keep that systolic where it's at. And as the systolic stays there, hopefully, if everything goes right, if we can get there, let's say we get there and we put a tourniquet on them, the body will start to recover. It'll build that bottom number back up. But if it doesn't, then eventually the heart is going to wear out because it's not getting the blood flow that it's supposed to get. We've lost a lot of it, which means it's not getting its oxygen. As the heart starts to wear out, the pulse is going to drop. When the pulse drops, now that compensation is no longer there for the blood pressure. So the blood pressure is going to start to drop again. We have run out of our compensation. So compensated shock is pretty much over. Now we're going to start to see our vital signs start to drop. And that's when they're circling the drain. They're going to start to get real ashen, real diaphoretic, pale, cool, clammy skin, start to lose their ability to stay awake. They're going to start wanting to go to sleep on you, that kind of thing. So those are your pucker factors. If you get to somebody who's lost a lot of blood and you get their vitals and their vitals are still high, that's pretty good. That means you got there while they're compensating. So hopefully you can stop the situation from getting any worse. But if you get there's a bunch of blood on the ground and they're already starting to lose consciousness, or you take their vital signs and their blood pressure is low, especially their diastolic is way down, the diastolic will eventually start to drag the systolic, the top number is going to drag it with it, and then both are going to fall. And your blood pressure is your biggest, to me at least, your blood pressure is going to be your single biggest vital sign when you're dealing with shock. Yes, you want to know your pulse too, but if you watch and look at your vital signs for your blood pressure, and we'll go over this at basic, at the boot camp, I will we'll have like basically a vital signs class, and we'll talk about what does what. They all work together. The pulse works to maintain the blood pressure. Blood pressure is meant to maintain your perfusion, which keeps your O2 sats up, all that stuff. We'll get into that more for you guys that want it, if you want to know more about how your vitals work. How well people compensate for blood loss is related to how rapidly they bleed. The faster they bleed out, the worse, the shorter they're going to have compensation time. And an adult can comfortably donate 1 unit or about a half a liter of blood over a period of 15 to 20 minutes. If anybody's gone to give blood, that's how much they take from you. And it usually sits around that time. If you lose a half a liter over 15 to 20 minutes, your body's really not going to notice it unless you haven't eaten that day, within the outside circumstances. If you're hydrated, you've been eating, you haven't missed any meals, then that amount of blood, you won't even really notice it. You can go on about your day. If similar blood loss occurs in a much shorter period of time, though, the person may rapidly develop symptoms of hypovolemic shock just because the body doesn't have time to compensate. Changing the diameter of your vessels, either to constrict or dilate, takes time. Your pulse will change, but your pulse alone won't keep you going for long because, again, now you're putting all the load on the heart. And if the heart's suffering from hypoxia as well, it's just going to run out faster. It's going to wear out. The age and pre-existing health conditions of your patient should also be considered, so make sure you get a good sample history. Blood loss is an extremely serious problem, to the point where we actually, I don't want you guys to get into the habit of this because NREMT hasn't updated their skill sheets to show this yet, but they moved hemorrhage. They separated hemorrhaging out of circulation in a lot of your assessments. Anytime you go to any kind of follow-on training after becoming an EMT, you'll see where your assessment changes to XABC. And what that means is when you actually will look for external hemorrhage before you even check their airway. Now, if you do that in the clinicals and in our boot camp, perfectly fine. Just understand in the registry test, the written test, that is not there yet. I have no idea why, because it's not new. That's been out for years, but it's just something that the registry just never put into its assessments. All right. You should consider bleeding to be serious if the following conditions are present. So poor general appearance and no response to external stimuli. If they are unconscious, that's a problem. Significant signs of shock, blood loss, rapid blood loss. And remember, you could lose a half a liter. If you lose it fast enough, you're still going to have problems with shock. Uncontrolled bleeding, significant MOI. So let's talk about different types of bleeds. We're going to start with the worst, arterial bleeds. These are the bleeds from your pressurized arteries that are actually getting beats from the heart. You know, they're under pressure every time. If you cut an artery, every time your heart beats, you're going to spurt blood. It's like Spider-Man shooting across the room. These are really hard to control. A lot of times, this winds up being a tourniquet, unless it's something. If it's all the way out at your wrist or on your foot, then usually that's not that bad. Well, I mean, it's bad, but it's not something that you may have to go straight to a tourniquet for. But let's say somebody severed their arm in the middle of their upper arm, way up at the brachial artery. That's a much bigger artery. The blood's going to be much worse. If you sever your leg above the knee, you're really, really, really going to be bleeding bad from an artery because your femoral artery is just half your aorta at that point. The bleeding is typically bright red because it's got oxygen in it, and it spurts in time with the pulse. So the worse this is, the longer you take to stop it, the worse their shock is going to be. They'll actually go into decompensated shock right in front of your eyes if you don't stop these. Your venous bleeds, these are dark red because there's not as much oxygen in them. They flow steady. I'm not going to say that it's a slow bleed, even though I think it does say slow in the slide. Yeah. Depending on what vein you cut, it could be a massive bleed. It just won't have that spurt to it. It'll be a constant flow. These are easier to manage in that sense that you're not fighting the pressure, but it doesn't mean that you aren't still going to have your hands full trying to stop these. All right, capillary bleeding, that's your paper cuts. When it comes to dealing with an emergency, I don't want you to really worry about capillary bleeding. If I tell you they've got a little bit of blood pooling up around their fingers or anywhere really, because any kind of skin scrape, if it's just a scrape, it's probably just going to be capillary bleeding. The only thing that I really want you to be aware of with capillary bleeding is that they're at high risk for infection in those injuries because their skin has been compromised, right? That's one of their main functions of their skin. But you're not going to die from capillary bleed. So when we're talking about life threats, you just move past all of that stuff. Stick to the venous and the arterial bleeds. We talk about clotting. Your bleeding, we talked about earlier about what it takes to clot. You know, if the blood stops moving, if there's an injury, that kind of thing. So bleeding tends to stop rather quickly, usually within 10 minutes, but it depends. If it's an arterial bleed, it can take longer than that. There's a couple of things that will play into that. Some internal mechanisms, whether or not they've taken any medications, exposure to air. Air will make blood coagulate. When the skin is broken, blood flows rapidly from the open vessel. The cut ends of the vessel begin to narrow or vasoconstrict. So your body, as soon as it realizes that it's losing pressure in a certain spot, it will start trying to constrict that blood vessel down. If you think back to the anatomy chapter when we talked about blood cells, and I told you guys that your platelets were kind of jagged. They almost looked like they were hooks. The reason being is they're designed to, as they leave a vessel, because remember, they're not supposed to do that. So by design, if they leave a vessel, they are supposed to hopefully hook onto things on the edge of the cut. So you'll get some that connect and get stuck on the blood vessel, and you'll get some more that connect and get stuck on those, and so on and so on, until eventually they have just completely occluded that hole, and then you stop bleeding. And that is your scar. That's your clot. But the body doesn't like clots. That is supposed to stop the bleed, but it's not supposed to be a permanent thing. So that being said, your body is also going to release chemicals that will start breaking those clots down. When we start talking about TXA or tranexamic acid, and probably in this chapter actually, we want, if it's a massive enough bleed, say like a crushing injury or something, we don't want them to break those clots up too fast because then they're going to start to bleed out again. They're going to have a hard time controlling it. Um, we'll get to that a little bit down the line, but that's what TXA basically does is it slows down the body's attempt to break the clots up. And we want the clots to stay there a little bit longer because we know exactly how bad that injury is. The body doesn't. Bleeding will never stop if a clot doesn't form unless the injured vessel is completely cut off, usually by a tourniquet. Despite the efficiency of the circulatory system, it may fail in certain situations like movement, disease, medications can mess with it. Removal of bandages. Do we ever remove a bandage as an EMT? Nope. Good. All right. Never. Does not matter how saturated it gets. It could be so wet it's almost dissolving in front of you. Don't remove it. Just keep piling more on. All right. If anybody ever saw The Simpsons, when Homer kept putting paper over the previous paper, the dog would use the bathroom, and then instead of changing it, Homer would just put more paper on top. That's basically what we do for these kind of bleeds. External environment, body temperature, and severe injury can also change it. How a patient has the ability to clot. So real quick, talk about hemophilia. Anybody ever had a patient or know anybody with hemophilia? You don't have to, by no means, give names, obviously, but have you ever encountered anybody with this? You had a PD patient with it. Oh wow. Yeah, I've not actually, in my experience, I haven't actually run across anybody with hemophilia. I know what it is. We've trained for it. We're aware of it, obviously, but just haven't. At least I haven't come across it where it's mattered. If I've had a patient with a stomach ache that had hemophilia, that's that didn't show up in their pertinent medical history. But these guys, as far as trauma is concerned, it sucks because they could have a small bleed, like say they just cut their finger, and they'll just bleed and bleed and bleed for days because they're missing those clotting factors. Because they're free bleeders is another term for them. It does have several forms. Most of it's hereditary. So if they've got it, they know they got it. You don't just wake up one day in your 30s and go, "Oh, I have hemophilia." Um, some are severe. Bleeding may occur spontaneously. I have a buddy I went to high school with, and his blood would just start seeping out of his veins, out of his vessels. No injuries at all. He would just start losing blood. His veins would just start permeating, and his blood would start to seep out. So there were days where it looked like he had dependent lividity. He looked like a corpse because gravity was pulling his blood down, but he was alive, kind of. Um, they he was in and out of the hospital for years as a teenager. They finally gave it a name. They had to make one up for him because there was no documented history of it. All injuries, no matter how trivial or potentially serious with these kind of patients, because like I said, even if it's small, they'll just what we would normally clot off. Like there's days where I'll look at my arm and be like, huh, where'd that come from? I have a bleed or I had one. I just got dried blood on me. But for hemophilia patients, those little injuries could just continue to bleed for hours and days or whatever. So if this is what you get, transport them immediately. Be prepared to use aggressive um, bleeding control measures, even if it's not what would normally be considered that bad of an injury. Internal bleeding. Internal bleeding is any bleeding in a cavity or space inside the body, be it the head, chest, abdomen, any of that. Remember, just because it's not coming out of their skin doesn't mean they're not bleeding, and they can actually bleed out enough to die on you without you ever seeing a drop. This can be very serious, and then sometimes it's very difficult to detect. When you're doing your assessment, and we talk about pressing down on the quadrants of the abdomen, if you're worried about internal bleeding, when you press, if there is blood in the cavity, you're going to tell because it's going to be a lot tougher. You're not going to be able to press it. It won't be an easy, smooth depression like it is in the other areas. It's going to be harder to press. If it's bad enough, it could get distended where it starts to bulge out because their abdominal wall is not used to holding all that blood, um, which we call distension. So if you're checking it, um, if I want, like if it's a scenario, I may tell you that your patient has distension in one or more of their quadrants. And what that is, I want you to associate that with bleeding. All right, either bleeding or it could, if it's not something you're worried about, internal bleeding, say it's a medical call, then it could be something along the lines of an organ being swollen. But for trauma, I want you to associate it with internal bleeding. Some possible conditions that cause internal bleeding: we have a stomach ulcer, lacerated liver, ruptured spleen, broken bones, especially ribs or femur, because they carry a lot of blood vessels, and your ribs are actually shaped like the letter C, kind of standing on its tips, and you have a lot of nerves and blood vessels that run underneath it. They're not just solid round bones. And then pelvic fracture. If you think of a skeleton, that giant saddle, butterfly-looking structure of bones in your hips carries a lot of blood. That's one of the reasons why elderly falls can be so bad, because if they fracture those, they're just going to bleed out. A high energy mechanism of injury should increase your index of suspicion for the possibility of serious unseen injuries. So if you show up and the car is completely mangled, but your person, as far as the outside is concerned, looks pretty decent, like they're not that banged up, just like we talked about in the last chapter, it doesn't mean that they didn't have some internal organ damage, some internal bleeding. They still need to be. You may have to talk them down and be like, "Do me a favor, sit down, lay down, whatever. Stop moving around. Please stop doing jumping jacks. You're not you're not convincing me that you're not hurt." That kind of thing. Um, and then give them a good assessment. Yes, I'm speaking from experience on that one. Internal bleeding is possible whenever the MOI suggests that severe forces affect the body. Blunt trauma, penetrating trauma can cause it. Usually, blunt trauma will be what causes you internal bleeding, but you can get it from penetrating. Even though there's a hole there, if the blood's not coming out of it, it's considered an internal bleed. So use your DCAT BTLS. We've gone over this a few times. So now you can see it on the slide. This is going to be your big acronym or mnemonic for your trauma calls. So you have deformities, contusions, abrasions, punctures or penetrations, anything that broke into the skin, burns, tenderness, lacerations, and swelling. Every section of the body that you assess, you're going to assess these things at minimum. And then depending on where you're looking, like if you're looking at the chest or the head or the neck, there will be a couple of other things that you throw in on top of that. But this is your baseline. So if you're just checking out somebody's arm, you're going to at least look for these things. And if you look at it, most of this has to do with the skin, right? Contusions or bruises, abrasions or scrapes, punctures or holes, burns are mainly about the skin. Tenderness is subjective. Your patient has to tell you whether or not they're tender. Tenderness doesn't mean soft. Lacerations or cuts, swelling is pretty self-explanatory. Deformities, if it's bending in the way it's not supposed to bend, that's a deformity. If there's a huge raised area like a bump or like a hematoma, that would be a deformity. Um, those are the things you're looking for. So most of that has to do with your outward appearance of your patient. Internal bleeding is not always caused by trauma. There are some medications that can cause this. There are some medical conditions that can cause this. So bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancies, severe, I know it doesn't say it, but severe, well, now I'm having a mini stroke here. What's the term? Constipation. Severe constipation can do this. Bleeding from the colon would be caused by that, but you could also have rectal bleeding on any of that stuff. Hemorrhoids, not all hemorrhoids are external, so that could cause internal bleeding. Aneurysms, and these signs are frequent but not always present. So you may have abdominal tenderness, guarding, which is where they kind of cross their hands over in front of their stomach like they're trying to protect it. Rigidity. If you go to press down, and like I said, it's a little bit more firm than you would expect. That's rigidity. Pain and distension. In older patients, you can also include dizziness, fainting, and weakness because again, their body's not going to compensate as well. So when their pressure drops, or if they go hypoxic because they have internal bleeding, the brain's going to have a harder time staying as level as it should be, and they may have a little drop in their consciousness. Sometimes that happens. Younger patients, our orthostatic vitals, we tend to compensate better. Where you go from lying to standing in a hurry, we don't typically pass out. If a 70-year-old person went from lying to standing real fast, they'd probably hit the floor. Ulcers or other GI problems may cause vomiting of blood and bloody diarrhea or urine. So keep in mind, if your patient's complaining about that, some of the questions you might ask them is, well, what does it look like? Is it bright red blood? Does it look kind of brown and like coffee? That gives you an idea of where the bleeding is in their digestive tract. It's not as important for you to know the specific organ that could be bleeding as it is to just recognize that the patient's in shock and respond appropriately. Because again, we can't bring them back from it. Once it goes down that road, especially once they start to decomp, we're kind of screwed. Even your paramedic's going to really struggle to get anything out of them. Your signs and symptoms of internal bleeding, pain is the most common. First of all, they've got the injury that made them bleed. That's going to hurt. But let's talk about, like, for example, I'm going to kind of jump the gun here, but let's say they're bleeding into their skull. If they're bleeding, um, if it's a hemorrhage in their skull, in their brain, they're going to have pain. You know, we talk about strokes, right? If it's a hemorrhagic stroke where it's because they're bleeding into their brain, there's going to be pain involved in it. If it's a clot that caused them to have their stroke, there's not usually pain involved. The reason being is because the blood's still in the system. Blood's an irritant. As long as it's not coming out of the vessels, there's really not any pain associated with it. So they're going to have pain from a couple of reasons, depending on if it's a massive bleed, massive internal bleed. They're going to be hurting everywhere that blood is at. It's going to make it kind of hard for them to really pinpoint where the problem is. And that can be a headache for you trying to figure out if it's internal bleeding, where's the bleeding sourcing from. Sometimes we don't know. The best thing we can do is just get them to the hospital and get them to a CT scan. Swelling, if there's extreme bleeding, distension, again, if there's extreme bleeding, it's going to kind of poke them out right there. The blood's going to push the skin out. Bleeding into the chest cavity or lung can cause dyspnea, which is trouble breathing, tachycardia and hypotension, and hemoptysis, which is bright red blood that's coughed up. Keep in mind, if they're bleeding into the chest is already full. It's kind of like the bus in Forrest Gump, you know, all the seats are full, can't sit here. There's really, the body didn't plan to have a bunch of blood hanging out in between the lungs and the heart. So if that blood starts to accumulate in the chest, it's going to start to make it to where the heart doesn't have the room it needs to be. The lungs don't have the room they need to expand. And so if you can't get that depth of lung expansion, or if you can't get that good beat, now your minute volume is going to go down. Your tidal volume is going to go down. Your stroke volume is going to go down. All that stuff. So your vitals are going to have to pick up. And you'll see that if they're bleeding out of the chest, it may not be that they've got that much blood loss. They may not look like they're going into shock, but their vitals are going to climb, particularly the ones that are sourcing from that area. Hematoma, this is a mass of blood in the soft tissue beneath the skin. So if somebody gets whacked in the forehead and they're bleeding outside the skull, that blood's going to start to make a big ass knot, right? And that is your hematoma. It has nowhere to go. It can't go in. It's got to come out. So it's going to make that huge, huge knot. Bruising, which is a contusion. We also call this ecchymosis. This may not be present initially, depending on how bad the bleed is in the skin. Sometimes it shows up later, like the next day, kind of later. And bleeding from any opening, bright red blood in the mouth or the rectum, hematuria, which is blood in the urine, and then non-menstrual vaginal bleeding. If they're bleeding from the vagina and it's not their time, that's usually a common sign. That's a big problem. All right. Hematemesis or vomited blood. It's bright red or dark red, depending if it's digested at all. If it's coffee ground appearance, that means it's really been digested pretty heavily. It could have been in the stomach for a while. Melena, which is black, foul-smelling, tarry stool with digested blood in it. Really, really stinks. Pain, tenderness, bruising, guarding, or swelling. This is usually possible with a closed fracture. If they broke a rib, for example, you may not see the rib break. It may not be poking out of the skin. That's why it's called a closed fracture. But they're going to guard it. It's just a natural reaction to pull your arms in because we recognize instinctually that our rib cage has been broken and our vital organs are at risk. All right, hypoperfusion, which is again, it's what we call shock. Change in mental status, such as anxiety, restlessness, or combativeness. A lot of times, that's going to be your first sign because the brain is the biggest baby in the body when it comes to telling you something's wrong. You're going to see a change in mental status pretty quick. Weakness, fainting, or dizziness on standing. Changes in skin color or pallor. So as the blood gets shunted away from your skin because it's needed elsewhere, you start to lose that pink look in your skin. You turn white, kind of pale. Without the blood there, that warm blood keeping your skin warm, it's going to start to get cold. So that's where the cool and clammy comes in. If you hear those things, it's because the blood is no longer in the skin. That usually means that for some reason it has been sent elsewhere, it's needed elsewhere. So if you're dealing with a trauma patient, most likely they've got a bleed, and it may be internal, that you have to try to deal with. Later signs of hypoperfusion suggest internal bleeding. You may have tachycardia, which is a compensated effort. Your heart rate's picking up, trying to maintain its blood pressure. Weakness, fainting, or dizziness at rest. Thirst, nausea and vomiting. Cold, moist, clammy skin. Shallow, rapid breathing. Dull eyes, where they're not quite focused on you. This is the best way to put that. Slightly dilated pupils that are slow to respond to light. So if you shine a light in somebody's eyes, their pupils should snap to the right constriction within like a half second. If you shine a light in somebody's eyes and it takes 2 or 3 seconds for their pupils to adjust, that's a major problem. Gap refill of more than 2 seconds in infants and children, but even then, don't don't get hung up on the 2 second rule. Use that for what it's really worth, which is trending. If you start off at 2 seconds and then a little while later you check it and it's 3 seconds or 4 seconds, that's a problem. If you start off with 3 seconds and you check it later and that's 2 seconds, well, that means you're moving in the right direction, so that's a good thing. Weak, rapid, thready pulse, decreasing blood pressure, or an altered level of consciousness. And patients with these signs and symptoms require prompt transport. So if you see any of this, it shows that they're going down the shock route. It's an immediately, I need them in the truck as soon as possible. We're going to do everything we can en route. So if your patient's still laying in the ditch, this is a good time for you to tell your preceptor or your partner, if it's real world, hey, let's get a quick head to toe, make sure we're not going to do more damage moving this guy, and then get them in the truck and let's go. All right, let's take a break. Be back at 7:04, or we'll say 7:05. Be back 5 after, and we'll get started with the patient assessment. All right, let's get back on this. So we're going to talk about the assessment. First of all, this will help me see who all's with me still, since I know this. We're just getting back from the break. But what's the first section of your assessment called? The first grouping, and it's the same whether it's the medical assessment or the trauma assessment. Not trauma. No, it's the same. That's the one of two routes you're going to go. But there's yep. All right. So you sent it in a private message, but you're correct. It's scene size up. So the first thing we're going to do is make sure that everything is safe, and also what are we looking at, right? Um, because you may walk into what looks like a disaster area and it wind up being just a diabetic patient, but it's going to look like there was somebody murdered there. Um, or it could be backwards. I mean, you may walk into a Stepford wife house and there's somebody that's been stabbed or whatever. So you're seeing size up at first. That is, make sure that whatever's there that hurt the patient is not going to hurt you too. And then when we're dealing with trauma, that's especially important because something external had to hurt the patient. It's not like you showed up to a stomach ache. You got to make sure that whatever it was that hit them, be it intentional or not, isn't still there to threaten you as well. So be alert to potential hazards. At vehicle crashes, ensure the absence of leaking fuel and energized electrical lines. Get a full picture before you walk all the way up there. In violent accidents, make sure the police are on the scene. Try to figure out if the person who did the attack is still there, if they've been apprehended or not, if they fled the scene. Keep in mind, if they fled, they can always come back. Sometimes when people act violently, they don't want the person who they just stabbed to get help. They may be there waiting and coming after you too. So if it's dark, get some lights up, get the cops out there, have some protection while you take care of the scene. Follow your standard precautions. You should have your gloves on pretty much as you walk up to the patient, be putting your gloves on. Eye protection if you need it or whatever. Determine your mechanism of injury. If it's trauma, keep in mind you may have a nature of illness. It could be a combination of the two. So determine your MOI and NOI. Consider the need for spinal mobilization and additional resources. If you feel like they got hit by something that could have caused whiplash, for example, if they're in a car wreck, if there's any traumatic injury to the neck, say they got stabbed or there's a obvious sign on their skin on their neck that they got hurt, then we're going to consider C-spine because our neck is not really designed to take a hit. Um, there's no protection there, none of that. The only thing that's protected in your neck is going to be your airway, which is pretty flimsily protected at that, and your spinal cord. And depending on what happened, you could hurt your cord. Consider environmental factors such as weather. For your primary assessment, this is your ABCs. Now, again, you are there to, at this point, you're trying to solve your life threats. So if you show up and we'll do this as an evaluation. If I told you that your patient you're going to respond to had, let's see, you see your patient laying on the ground, he's unconscious with like cool and clammy skin. There's a fairly large pool of blood at the base of his left leg, and his right leg has an obvious deformity at the knee where it's bent backwards from the direction it's supposed to go. Um, what do you think your major concern would be right there of everything that I just said? Blood loss, right? Okay, because he's cool and clammy. Could have internal bleeding. That's good. That's something you want to keep in your mind. If you see blood on the ground, give it a quick look. Make sure he's not actively bleeding out from that wound. The bleeding may have been controlled before you got there. Um, it may be that he is selectively bleeding. If it's a significant bleed, then you're going to fix that and move into your ABCs. Um, if I didn't give you a bleed, if I didn't give you a hemorrhage or whatever, it's real easy sometimes to get that tunnel vision, and you're going to be like, oh God, I got to fix that leg, or something like that. That could be a gruesome, very distracting injury. But you have to ask yourself, as bad as that injury is it going to kill him in the next 30 seconds? If not, then it can wait. Yes, it probably does need to be fixed, but if not, then we can push it down the road. You're really only worried about what's going to kill my patient right now in the primary assessment. Then, when you get those fixed, you're going to go into your secondary assessment, and you're going to worry about the things that are going to kill your patient or seriously maim or injure, um, a little bit down the road. You got a little bit more time. You got the immediate threats out of the way. Now you're going to work on the moderate threats, and then when you get those on, you're going to go over it again at the lesser threats, and then just eventually, if you had enough time, you would eventually make enough rounds of your patient from head to toe to start like just cleaning up blood off the skin. A lot of times, though, in EMS, they're at the hospital by that point. That's usually what your CNAs are doing. Your ER techs may be doing that kind of thing. So we concern ourselves with making sure that they are stabilized as best we can and that they don't die on us on the way to the hospital. So in your primary assessment, form your general impression, sick or not sick. When it comes to trauma, I want you to think dying or not dying, shock or not shocky. Note important indicators that alert you to the seriousness of the patient's condition. Be aware of obvious signs of injury and distress. So, not everything is going to be the obvious, like the leg is, you've lost your arm kind of thing. Sometimes it may be that you just look at them and they've got a big facial grimace or they're screaming in agony and that kind of thing. You're like, all right, you're hurt. Let's take a look. Determine your patient's gender and age. You're going to perform a rapid exam of your ABCs. You're going to look for your life threats and treat them as you find them. So if you find a problem with A, don't just push it to the side and finish your ABCs before you fix it. Fix A when you find it. Then you move to B. Fix any problems with B when you find it. Then you move to C. Fix any problems with C. The exception to this is I want you guys to think severe external, gonna die if I don't do something about this hemorrhage. You can put it first. Just keep that one in mind. Your test, like I said, I hate to say it because your registry test is going to be a little bit different, but your registry test is not going to give you that option. So just keep that in mind. Your registry test is going to have you do ABC. They're not going to separate hemorrhage. So you can remember that. And if you see it in the test, it shouldn't trip you up because that option won't be there as a distractor. If the patient has obvious life-threatening external bleeding, address it first. Assess your skin color. Determine the level of consciousness using AVPU. Again, we're not at the point of getting a Glasgow Coma scale yet. We don't have to be that specific. I just want to know, is he alert, unconscious, or somewhere in between? For your airway and breathing, consider the need for spinal immobilization at this point. If they've taken a major hit anywhere from the chest up, I would really consider putting a cervical collar on them. If it's just the collar, you're not going to go wrong by doing it. The things that we've gotten away from, like the longboard, those were causing damage, but we don't liberally put that on patients anymore. Ensure a patent airway. So if they're alert and talking to you, or if they're alert and screaming or any of that sort, they have a patent airway. You can just leave it at that. Look for adequate breathing. You want to see that they're breathing about 10 to 12 times. Anywhere between 12 to 20 is normal. If they're in that range or even just a few out of that range on either side, that's okay, as long as the breathing is deep enough to constitute a real breath. Somebody's breathing 22 times a minute, but it's really, really shallow. That's a problem. It's at this point, too, that I want you to expose the chest and look at their chest for 2 injuries. So when you get to the B in your primary, and I'm going to foot stomp this. I'm glad I'm being recorded, so you guys, if you go back and watch this again, you'll hear it again. 2 specific things I want you to look for when you assess the breathing in your ABCs, and that's going to be a sucking chest wound, which tells you that you have a problem in your lung, right? You have a hole in the lung because when they take a breath, it's pulling air in. And that problem is only going to get worse if you don't fix it. It's going to get to a point where the lung can't expand because there's too much air outside the lung and in the chest. So a sucking chest wound. And I also want you to look for a flail segment. There's really not a lot that we can do with the flail segment. We used to talk about bulky dressings. If any of you have ever heard those before, they're going away. We found out they really don't do anything. Just note it. You can try to stabilize it. You can take like a compression bandage. Either we call them like an Israeli bandage we'll show you at boot camp. You can take something along those lines and wrap it around their chest to kind of help provide a little bit more stabilization, but that's really about it. The big problem with the flail segment is that those broken ribs can puncture the lung. So those are why I want you to look at it at breathing, is because those are threats to the lungs, those two injuries. Provide high flow oxygen. At this point, we don't have an O2 sat, right? We're nowhere near our vital signs. We're not that far down the list yet. So give them high flow. But just be aware that when you do get to your vital signs, you may decide to dial it back a little bit to keep them in a good oxygen range. Insert an OPA if they're unconscious. If they take it, great. If not, pull it out of their mouth, put an NPA in their nose. That is a patent airway for an unconscious patient. And then moving into your circulation, assess for pulse rate and quality, determine your skin condition, color, and temperature. Again, that's a huge sign of whether or not they're going to go into shock, because if it's internal, we don't see the blood loss. However, if we see their skin changing color, we know that they're shunting it somewhere, or they're just losing it, one of the two. Check your cap refill time. Again, don't get wrapped around the axle over the time. Just worry about trending. It should hopefully either stay the same or get faster. Control external bleeding, treat for shock, apply oxygen, as we already talked about up there. Try to improve their circulation. If they don't have a pulse that's adequate to sustain life, then you may have to do some chest compression, or if they just flat out don't have a pulse. Maintain a normal body temperature, so cover your patient. When we talk about treating for shock is keeping your patient warm, flat, and hopefully not continuing to bleed out. So you can give them some oxygen so that the blood they do have is passing it around, and then keep them warm. Because what happens to our blood flow when we get cold? What do you think happens to the blood vessels in your skin or in your hand when we get cold? Yeah, it slows down. It slows down. Your blood vessels constrict, because you're trying to keep the core warm, and so it actually winds up hurting your circulation even more if you get cold. So you keep them warm, it causes the blood vessels to dilate a little bit, put some more blood in the system after a while, and then hopefully you actually maintain some vitals pretty well. Here it says for your transport decision, any problem with the ABC, there's a high priority for transport. If you see any signs of shock, or if their vital signs are looking like they're compensating for something, so here on the slide, tachycardia or tachypnea, low blood pressure, a weak pulse or clammy skin, that's a sign that you need to get some copious amounts of diesel going and get them to a hospital. For your history taking, we're going to get our sample. Look for signs and symptoms of other injuries due to the MOI. Note obvious signs of internal bleeding. Remember we talked about that, like your distension, your the rigidity in the abdominal area, that kind of thing. Changes in skin color, any severe pain, guarding. Note out, let's see, in a responsive trauma patient who has an isolated injury with a limited MOI, so in other words, like let's say they were skateboarding and they fell off the skateboard. Consider doing a focused assessment before assessing your vital signs and obtaining a history. If they tell you they broke their leg, then that's it. That's their only complaint. Just look at their leg. You don't have to poke and prod on their head if they're telling you they're alert and they're telling you that they just hurt their leg. But if they're unconscious, if it's a car wreck, if it's something that looks like it's a massive injury, then yes, do a head to toe. Get your sample, like I was saying, so signs and symptoms, allergies, medications, pertinent medical history, your last oral intake, and the events leading up to. And I've noticed some curriculums out there now are starting to add an R. They're taking it from sample to sampler. The R at the end stands for risk factors. You may or may not see that by the time you go to take the registry. Just be aware of it. Risk factor being like, are they geriatric patients? Are they heart patients? Any of that stuff. It could be something for you to just take note of, especially if they're bleeding and you're worried about them being like a hemophiliac. That would be a risk factor. So that's coming. I don't know when it's going to hit the curriculums, but it may wind up being I mean, I've already seen it in other classes, so it may not be long before the registry puts it in. For your secondary assessment, record your vitals, complete a focused assessment of pain, so get a good OPQ-RST. Attach appropriate monitoring devices like your O2 sat, your blood pressure cuff, and with a critically injured patient or a short transport time, there may not be time to conduct a secondary. That may happen. You may not get a sample history. You may not get a set of vitals. If you have to pick one or the other, go ahead and get the vitals, just because you can get a lot of information from that. Um, Sample history may not necessarily be as important as knowing that they're going into compensated shock. You're going to assess every area of your assessment for DCAT BTLS. So it's going to be your head, face, neck, chest, abs, pelvic area. You just go straight down the center of the body. Then you're going to hit your arms, your legs, you flip them over, check their back. If you, at this point, if you're going to put a board on them, you would put a board on them and then fasten them down. Remember, we cut our abs into 4 quadrants. So you have your left and right upper above the belly button and your left and right lower below the belly button. And then get a pulse, motor, and sensory function in each extremity. So what I do is as I work my way down, when I get to their feet, I put my hands on top of their toes and I tell them to push against me so like they can try to pick their toes up. And they don't have to do it hard. I want to make sure that it's even. If I tell them to do it with both feet and I only really feel one foot put any pressure, the other one's just kind of barely there, that tells me that they have some motor function issues. Feel a pulse in both. Make sure that you have a pulse in both feet, especially if your injury is to their legs. If you're worried about blood flow getting past the injury, you want to check that pulse. Do the same thing with their hands. Have them squeeze your hands. You should feel at least similar strength in both sides. If one's a little bit weaker than the other, it's not that big a deal. But if one is significantly weaker than the other, that's a major problem. For your vital signs, assess your baseline vitals and observe changes that may occur during treatment. Again, remember, when they're compensating in shock, you're going to see your vitals are going to climb at first, and then as the body continues to wear out, if we don't find the problem and fix it, the vitals are going to start to fall, and that's where it starts to get bad. So know your baselines, know what your normal ranges are. If everything's hanging out kind of high, that's cause for alarm, but at least it's still compensating, so you're ahead of the game at the moment. You see them getting cool and clammy, and their vital signs are starting to get low. That means you're behind the curve. Your patient's starting to circle the drain, and you may wind up doing CPR before it's over. Let's just be aware of that. In geriatric patients and patients who take certain blood pressure medications, the pulse rate may not increase with early shock. Remember we talked about beta blockers? They may climb. If they're taking hypertensive medications, the blood pressure may not be able to climb. The body's going to try to compensate, but that blood pressure is hitting a glass ceiling, and it's not going to be able to climb, which means that they're not going to compensate for long. They're going to start to fall faster because the medication is stopping the body from doing what it's trying to do. For your reassessment, if they're unstable, which most of the time in massive trauma, they're going to wind up being pretty much unstable as far as an EMT is concerned, repeat every 5 minutes. Check your ABCs every 5 minutes, especially if you had to put a tourniquet on them or something of that sort. Make sure that everything is still in place and they're not continuing to bleed out on you. As we move our patients, every time we move them, we run the risk of dislodging a tourniquet, knocking it loose, creating a new bleed, aggravating a bone. If they had a broken bone and we're manipulating them, we might wind up, they may not have punctured an artery prior, but if us moving the bone, we could cause that. So we're going to try to minimize movement of our patients. We'll get into that when we start talking about musculoskeletal injuries. But as you can see, as you're going through your assessment, you do run the risk of causing problems that weren't there before. So we have to be careful with that. That's why we reassess. Doesn't necessarily mean you did something wrong. It's just a possibility. Always, always, always provide high flow O2 early in your assessment if it's a trauma patient and they've had blood loss. You don't have to keep them at 15 liters non-rebreather. And in fact, the curriculum, the registry does not want you to. But it's still a critical fail if you fail to do it initially. You can always dial it back, but don't just withhold oxygen. And then your communication and documentation, we'll get into that more at the boot camp about what to document, how to communicate. When we do your actual evaluations, not your, I'm sorry, when we do your assessments, we're not going to tell you when you're done, right? Your instructor will give you feedback, but when you're in your assessment, we're going to be kind of treating you kind of like your evaluators going to treat you. We're just going to sit there and stare at you, and we're not being mean. But what's happening is we want you to know if you missed something. I want to see if you can catch it and go back and get it. So if you think you're done and you look at me and you're like, I think I'm done, I'm just going to be like, are you? Even if you did it perfectly. Like I said, it's the point is to see if you did miss something. If I tell you that you're done, I took away your opportunity to go back and fix it. And then at that point, if it was an evaluation, if you missed a critical, then you failed. And it was my fault because I didn't give you the opportunity to go back. So we won't tell you you're done. We do you a disservice if we do that. So I want you guys to really, especially at this point in the game, we're in module 4, you should be getting those assessment sheets pretty well memorized at this point. So that when we get to the boot camp, we can actually start doing some practice runs and doing skills and getting your hands on the mannequins and going through the interventions and everything. But anyway, reassess every 5 minutes. Like I said, we'll talk about your communication. When you get to those assessments, that's how we'll know you're done. We're going to let you do a handoff. You're going to tell me what you've got, give me your vitals, any interventions, and then when you say I have handed off my patient, that tells me that you're done. Better or worse, you have done everything you can think of. Any questions so far on your assessment? All right, cool. All right, so let's talk about some emergency care. And we're going to really go over this at the boot camp because this module is mostly hands-on, but I'm going to talk about some priorities of how we do things. So first of all, follow your standard precautions. You're dealing with blood. We don't know what our patients have, and HIV is a bloodborne illness. There's a lot of bad juju out there that you can get from blood. Hepatitis is a bloodborne illness. So we don't want to get that on us because you might have a little nick yourself that you didn't even realize was there, and then you get that blood in there. Now you've got a sickness. So wear your gloves, wear your eye protection, and if it's a murder scene or if it looks like one and they're spurting blood everywhere, you may want to mask and gown up. It just depends on what you're dealing with. Make sure that the patient has an open airway and is breathing adequately. Provide your high flow. And if obvious life-threatening bleeding is present, control it as quickly as possible. If you show up and if I told you that your patient was, if they were severed at the knee and they have an arterial bleed that is shooting massive amounts of blood on the ground, I really would like for you to fix that first, because what good is the ability to breathe if there's no blood in the system to maneuver it around? You can hold your breath for a couple of seconds, at least long enough for you to put a tourniquet on them, then go to your airway and breathe in. That's okay. Several methods are available to control external bleeding. There used to be more. They actually took one of them away, which is nice because it was a complete waste of time. So you have your direct pressure, where like if I'm bleeding out of the wrist, the first thing you do is you take with your gloved hand and some 4x4 dressings, you pinch down on the bleed, right? You put pressure on it. That's your first step. Hopefully, and in most venous bleeds, that's enough. If it's an arterial bleed, though, you may find that it's still bleeding through. It's going to be seeping out of around your hand. All that's not enough. So the next step is pressure dressings or splints. It's where you take something constrictive and you can not to the tourniquet level. You're still dealing with the injury site itself. You can take cling wrap it really tightly around the wound or whatever, and it basically does what your hand's doing, but it also has that absorbent factor to it because it's a bandage. If that doesn't do it, then we go to tourniquets. Your tourniquet is going to be high and tight. It's only for the extremities. Obviously, you can't tourniquet the neck. You can't tourniquet the chest as much as you might want to do it to somebody. Don't try it. So your tourniquet's going to go on your arms or your legs, depending on if that's, whichever one's got the injury. They used to teach that it was 2 inches above the injury, not on a joint. But if you're to the point of a tourniquet, I want you guys to just go high and tight, all the way up into the armpit area, all the way up into the groin area, and then crank it down right there. Don't worry about measuring 2 inches off their wound or whatever. If it's that bad of a bleed, you're wasting time, you're wasting fluids that your patient is going to be losing. So direct pressure is the most effective way to control external bleeding, as long as it's not something that's too terribly massive. Pressure stops the flow of blood and permits normal coagulation to occur. The only thing about this is, like I said, if you're going to do this, which should be your step one, there's nothing wrong with that. Take some 4x4s that are going to be the bandage, and the minute you put pressure down, have those bandages there. Because if you don't, you might control the bleeding, but you're going to have to put a bandage there. So if you move your hand and there's no bandage, you basically your hand is the bandage and you've removed it. So if it started to clot, you removed the clot. Now you're starting over. So what I do is I get at least one 4x4 in my hand and I put pressure there. And while I'm holding it, I can be grabbing more 4x4s, open them up, get them ready, move my hand, leave that original bandage where it's at, place more bandages on top of it. And then if that starts to stop the bleeding, great. I can wrap it up and secure it in place, and I'm good to go. If not, then I will grab a pressure bandage. Splinting can do it, and I'll show you how to properly position somebody with a splint to stop their bleeding. If that doesn't do it, or if I walk up and I know that's not going to do it, then I'm not going to waste my time with it. Like I said, if you've got somebody that's lost their leg at the mid thigh, there's no way that any of those two steps is going to do anything for that kind of blood loss. So you're going to go just straight to the tourniquet. Sometimes that is your answer. You just go straight to the tourniquet. All right. So we talked about your pressure dressings, and then your tourniquets is your third step. Now we can only tourniquet the extremities. So what if let's say it's an active shooter situation, and we're worried about something mid center mass. They got shot in the chest, shot in the stomach. You can't tourniquet that. So we have a couple things out there. They're called hemostatic agents. Basically, they are liquid reactive. They're not blood reactive. They're liquid reactive. When they get wet, they cauterize into a solid block, and then they basically would seal off. They would become the clot of whatever bleed you're putting this stuff on, and it's fantastic. It works really, really good. There's just a couple of downsides to this that you guys need to know about. First of all, there's two types, and the first one is what we use in the military first, which is granular powder. This is where you just pour it into the wound, and it creates a tight seal. Fantastic. But again, it's in a pouch, and it's not blood reactive, it's fluid reactive. So what we were seeing downrange was basically medics would have this pouch. They're holding pressure with one hand. They put the pouch, grab it with their mouth, rip it open. Powder goes everywhere, gets in their eyes, and now their eyes are cauterized shut. That kind of thing. So now your medic is a patient as well, and he can't see what he's doing. So what they have done, most of your new hemostatic agents are now a gauze that's impregnated with the clay substance, and they're used for wound packing. Yeah, quick clot. That was the stuff that we used to have. Worked great as long as you didn't get it in your nose, mouth, or eyes. That was the only scary part about it. Even if you used both hands to open it up, there was always that chance that it was going to poof right in your face. And then you were screwed. Because the only way to remove that is by surgery. They have to cut it out. So that's a bad day for you and your patient. But anyway, I digress. The second thing that they came out with was a impregnated gauze. So if you have a patient with a hole where they've been shot, you would basically open the pack. There's no loose powder. It's all inside the gauze, and you just pack it in. Just keep pushing it in until you can't fit anywhere. You'd be surprised how much of that you will fit inside of somebody. But you just keep going. Put the whole pack in there, and if you run out, take another pack, put that pack in there. Those work a lot better. They're a lot safer for the medic, which is always a good thing. The use of hemostatic agents in EMS remains largely experimental. It's becoming more common. In fact, we use Quick Clot in the military, but there's a brand called Celox that is basically just the civilian equivalency of it. A lot of your first aid kits have it, so that's a good thing about it. But again, like I said, keep in mind if you're going to use a hemostatic agent on a patient, um, that's not something that's just going to be removed easily. That's something that a surgeon is going to have to dig it out. But again, I mean, at that point, they're in the hospital on the OR table anyway, so it's fine for them. Just know that just a little quick clots, or you put it in there. It's not like a bandage. They're not going to just remove it. It's not that easy. For your tourniquet, this is what you're most likely going to see in the field. But again, these are for extremity hemorrhages only. The tourniquet is useful if a patient has substantial bleeding from an extremity injury. Several different types of commercial tourniquets are available. I prefer the cat tourniquet. There's a couple others. There's junctional. There's one that is just a giant flat rubber band that doesn't even have a securing device. You just put it on them, pull it tight, wrap it around, keep doing it, and it when it retracts back to its normal size, it pinches off their blood flow. You can hand make them. There's nothing saying you have to use a commercial tourniquet. You can make them yourself. You can make them out of a pillowcase and a TV remote, or any of that kind of thing, depending on where you're at and what you've got. They are, as long as it does the job, that's really what matters. When you apply a tourniquet, make sure you observe the following precautions. First of all, don't put it over a joint. That part's always going to be there. Another issue, and this is one of my biggest gripes about saying put the tourniquet 2 inches above an injury. What if your injury is at the wrist? How good do you think a tourniquet's going to be if you go 2 inches above the wrist into the middle of the forearm and try to put a tourniquet there? And for those of you who obviously know that that's not going to work very well, can you tell me why? Can't really compress the artery at that point. Exactly. That's the problem. There's an anatomical reason why a tourniquet is not going to work on the lower or on a distal portion of your extremity, be it your forearm or your shin, that kind of area. Whereas a tourniquet would work really well on the upper portion of your extremities. What's different? Size is different, yeah. All right. Think about your bone structure though. The difference between your forearm and your upper arm, or your lower leg and your upper leg, is the amount of bones you got. Your forearm, you have two bones that's designed to allow you to twist your hand up and down, right? Pronate, supinate, that kind of thing. Um, if you try to put a tourniquet there, those two bones are going to restrict your ability to really crank down to the point of cutting off an artery. So you have to crank down that much tighter. And yeah, the way the bones cradle the arteries. If you crank down tight enough on the forearm, for example, to shut off the blood flow, and it's an elderly patient and it snaps their bone, your tourniquet that's an example of where your tourniquet has failed. And the tourniquet is not the problem. The problem is where you placed it. So I don't buy the two inches thing. I think that was a bogus thing. I don't see it in the curriculum anymore, which is great because I think they finally figured out that was a dumb idea. Just go high and tight. All right, your upper arm, your upper leg, it's a single bone. That dual bone there that's messing with your ability to really constrict the blood vessel, you don't have that problem up high. And you don't have to sit there and be like, have I gone far enough away from the injury? Just put it all the way up, tighten it down, and be done with it. There's also much less movement, right? Much less chance that they're going to whack it on something. If you put it halfway down your forearm, I've got all my range of motion, assuming I didn't break my shoulder, to hit the side of the ambulance or roll over on it, that kind of thing. If it's up higher up, closer to my trunk, I can move my arm 180 degrees and that tourniquet's only going to move an inch or two. You can place padding under the tourniquet if possible to protect the tissues and help with arterial compression. Never cover a tourniquet with a bandage. Just leave it open. If you do put a tourniquet on, make note of the time that you put it on, and a lot of your commercial tourniquets actually have a piece where you can write that down. If you can't write it down on the tourniquet, you can either write it down in your notes. If you're dealing with a mass casualty incident and you don't necessarily have a chart for everybody, you can write it on the patient. So something we've done in the military is we'll use the patient's blood, and we'll just on their forehead we'll put a quick time. That way we know when we put the tourniquet on. They've shied away from tourniquets for a long time in the civilian world because, oh my God, it's going to do nerve damage, despite the fact that without having the tourniquet, your patient's just going to be dead. But they're starting to come back. They're starting to realize that it's not that bad of a thing. And if you keep track of the time, not to mention how fast we usually get people to the hospital, they're able to do the surgery and take it off before nerve damage happens. And yes, don't remove it. Treat it like a bandage. And once you put it on there, it stays on there. Let the doctors remove it, because most likely what's going to happen is that blood is going to try to return and flood down there. And now you're also going to be circulating some possibly dead cells. And that's also going to be a big thing here in this part when we start talking about splints. So as you can see on the slide, we're going to start with air splints. These are also known as soft splints or pressure splints. What you're looking at there obviously is for the arm. They make some for the legs as well. They're called mass trousers, and they are no longer really in the service just because of some issues. So I'm only going to kind of hint on those, mainly because you will see, or not say you will, you could still see these in the system, and we can use them for the same reason, which is nice, but at least they're not as bad as your trousers were. These can control internal or external bleeding associated with severe extremity injuries, even though they're primarily used to immobilize fractures. Act like a pressure dressing applied to an entire extremity rather than to a small local area. So pressure dressing would be just over the side of the injury. This is over your entire arm, and it just constricts the blood flow. That's all. All it is pressure. Some things to watch out for: if they have an open fracture, a bone sticking out of the skin, obviously the bone could puncture that, and then your splint will fail. So if they have an open fracture, this may not be the way to go. If they have a closed fracture, then okay, you could possibly do that, and that's what it's meant for. But an open fracture where the bone's out of the skin, the bone could pop it like a balloon, because that's basically what it is. And then you don't have a splint anymore. You've just got a piece of plastic over your patient's arm. Use only approved, clean, or disposable valve stems when orally inflating air splints. And these splints will actually help immobilize fractures. They reduce pain, especially if the bone is free moving. They'll prevent further damage to soft tissue injuries. And once the splint's applied, monitor the pulse. Make sure that you didn't make it so tight they can't get any blood flow through. All right, you still want to be able to, even if they're bleeding out. Remember, you don't have just one artery running down your arm. So make it tight enough that you can control the blood flow, but you don't want to make it so tight that you don't get any blood flow. You still want to get a pulse, if possible, past it. Bleeding from the nose, ears, and mouth. Pretty much all the stuff we've talked about so far won't really work on these. Well, I take that back. Quick clot will, but be careful putting it around these areas. Bleeding around the face presents a risk for airway obstruction or aspiration. Several conditions can result in bleeding from the nose, ears, and mouth, including a skull fracture. Not even just skull fracture like what you can see. We're not just talking about the top of the head. We're talking about the cribriform plate, the basilar skull, kind of inside the face behind the nose, depending on where they got hit. That can be where they're bleeding from. That will go into the oral cavity. It'll go into the cranial cavity. It can cause a lot of problems depending on where they're bleeding into. Facial injuries, including those caused by direct blows to the nose, sinusitis, which is an inflammation of the sinuses, infections, and use and abuse of nose drops, cocaine, any of that kind of stuff can cause bleeding from your nasal cavities. High blood pressure can do it. Coagulation disorders can do it. Digital trauma like nose picking. If somebody's something I used to see this happen on the playground when I was a kid. Somebody would be picking their nose, and the bully would come up and like hit them hard on their elbow, which shoved their finger way up in there. And I mean, well, I don't know whether that was funny to somebody or not. That could cause some serious damage. That is something where you get your fingers shoved way up into your brain cavity. Um, can cause some major problems. But nobody ever thought of that as kids. Epistaxis, and no, I was not the bully that did that, by the way. Epistaxis is a nosebleed. This is common. It's not always trauma related. Sometimes it's just weather. Occasionally can cause enough blood loss to lead to shock. That's really, really rare. The problem there is if you're bleeding from the vessels that are supposed to feed the brain, you can go into kind of you're not really hypovolemic. You're just not getting it where you need it. Occasionally, the blood you see may only be a small part of the total blood loss, and much of the blood may pass down the throat into the stomach as the patient swallows. Usually, if that happens, they're going to have nausea and vomiting. So if you see a nosebleed with bloody vomit, that will tell you right there they're bleeding into their stomach. It's just going down the back. A person who swallows a large amount of blood may become nauseated and start vomiting. I just said that. Cool. Most non-traumatic nosebleeds occur from sites in the septum, the tissue dividing the nostrils. Anybody a fan of Stevie Nicks? Just me? I don't know if anybody in here even knows who Stevie Nicks is. Anyway, um, in the 80s, she was a singer for Fleetwood Mac, but in the 80s, she had done so much coke that she actually wore a hole in her septum between her nares, between her left nostril and right nostril. We're just old, Donna. That's all. But anyway, she actually had to have surgery to fix that. She got to where she couldn't sing anymore for a while. There was an interview when Fleetwood Mac got back together to do. I think it was one of their album Tango in the Night or something. I forget which because I was watching that documentary and I'm a Fleetwood Mac nut. But she was all upset because they didn't really feature in any of the songs, and one of the reasons was she was doing too much coke, never showed up to the rehearsals or anything. They just kind of edited her out. Um, and it was also the fact that she couldn't sing at the moment because she had that hole in her nose. Um, you may come across patients that have similar issues, maybe not because they've snorted the outline of the country in cocaine, but because they have some issues there. Bleeding from the nose or ears can follow a head injury. If they were in a car accident and they hit the glass real hard or something like that, this could be a skull fracture that they're going to see. You're going to see the blood coming out of their nose or ears. This can be really hard to flow or to control rather, and don't try to stop the blood flow. If they're bleeding from the nose or the ears, just let it go. Um, there's not a real easy way to do that. If they're bleeding from the nose or ears because of a head injury, let it go. If it's just a nosebleed, if there's no sign of head trauma, then you can do what the slide says, pinch the nose, it'll help out. But if you think they're bleeding from their brain cavity, just let it go because the alternative is going to be that blood's going to start to build up in the cavity, build pressure, and you're going to go from just a blood loss problem to a blood loss problem and a TBI that can kill your patient. Applying excessive pressure to the injury may force the blood leaking through the ears and nose to collect within the head. This can cause your TBI. So what we'll typically do is you'll just take some 4x4s and lay them up against the ears, lay them up against the nose a little bit. Don't obstruct their airway, but try to get it to where it can just kind of soak the blood up as it comes out. Apply light compression by wrapping the dressing loosely around the head. And a target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebrospinal fluid. Is that on the next slide? That's on this slide. Okay. So if you look at this picture, this is a 2x2 gauze. You can see a little bit of blood on there. And at least on my screen, it's kind of dark and not easy to see, but it looks like there's a yellow haze around it. That is cerebrospinal fluid. Um, that is typically only found in the cranial cavity with the brain and then the spinal cord. So if you're getting that in your blood, that means you definitely have a head injury. That bleeding is coming from that area, and that fluid is leaking out as well. Um, and if you're not sure, let's say it's coming out of the ears and you're not sure, you can actually take a glucometer and just, some of the blood coming out of the ears or nose, just take a reading of it. If it comes back with the sugar really, really high, that's another way to know that there's CSF, because there's a high glucose concentration in your CSF fluid, much higher than what's in the blood itself. So if they're not hyperglycemic, you would have a normal blood sugar, but the blood coming out of the head has a really high amount. That's CSF fluid. Yeah, I think you told me about it, Sharon, the one that you saw when you were with Keith, or yeah, yeah, those aren't good calls. I mean, they're not good for the patient. Um, it's not something that it's not a death sentence, but usually that's a massive problem. And that's another thing you want to, if you see that, surgery is the answer. They need to get to a hospital. There's not a lot that we can do. Even as a paramedic, your hand's going to be pretty well tied on these. DOA, yeah. Um, I don't think you told me about that one, but sometimes it happens. If they are alive, hurry up and get them to the hospital. All right, and then the last thing we're going to talk about, emergency care for internal bleeding. Controlling internal bleeding or bleeding from major organs usually requires surgery or other hospital procedures. We can't really do anything about this, unfortunately. So if this is what you're dealing with, an internal bleed, keep the patient calm, give them oxygen. You can try, if you find that one agency that does have mass trousers, learn about them. I'm not going to teach in this class because they're not even in the curriculums anymore. But learn your protocols on using them. Sometimes they work. They work great. It's when you take them off that's the problem. And a lot of times your ERs don't do it right and your patient dies. But anyway, give them high flow oxygen, maintain a body temperature that's conducive to life. You want to try to keep them warm. Splint the injured extremity, usually with an air splint. Never use a tourniquet to control the bleeding from a closed internal or soft tissue injuries. If they're bleeding internally, don't bother with the tourniquet. The tourniquet is for external bleeds of the extremities only. And that's it. Any questions tonight? If not, I have a couple for y'all while I'm pulling up your pen just to see what you think. So if you have a patient, no question. Okay, perfect. I'm not going to call anybody out. I just, if you know the answer, then you can unmute and say it. You can type it. That's up to you. Let's say that you've got a patient. He's unresponsive in a restaurant parking lot, and you show up. You've done your scene size up. You know your scene is safe. You're there. You look at your patient. You've stopped his bleed. Now he's got a lot of blood on the ground. What's your main concern at this point, just with what I've said?
Airway.
Airway, good. All right. Yep.
Control the bleeding.
Yeah, well, you've controlled the bleed, but there is a lot of blood on the ground. So in response to you're still going to do your ABCs, but in response to the blood loss, what are some things that what's going through your head as an EMT if you see a whole lot of blood on the ground?
Shock.
Shock. And what is, somebody define for me what shock is? What's actually happening in the body? Not their vitals, but when we say shock, what does that mean?
His body goes into shock. You said, what about see
Michael,
where the laceration on the body is?
it's not so much about the injury. It's about the lack of blood in the body because they've lost a lot. So, Michael Allen, you did a good job. You've basically defined shock. It's not enough oxygen to the cells, and it can be for any reason. Tonight's chapter was about blood loss. So You show up to a patient, there's a lot of blood on the ground. You can pretty much assume that the patient is going to be hypoxic because the only way to get the oxygen to the cells is to have enough blood in the system to carry it. So that being said, as far as interventions go, other than stopping the bleed, what is something that you'll want to give your patient? O2. Yes, lots of O2. Good. All right. And at this point, if they're hypovolemic, you can go ahead and give them 100% non-rebreather. If you're dealing with a lot of blood loss, don't worry about the whole titrating to 99%. It's probably not gonna. If they've lost a lot of blood, you're not really gonna get those numbers. So just give them high flow O2 and get them to a hospital. All right. If you show up to a patient, we'll say it's a suicide attempt, and they cut their wrists. You show up and you see a steady flow of bleeding coming out of both wrists. What kind of bleed is that? Venous. Good. All right. How would you fix that bleed? What's your first step? Okay, direct pressure. Good. And if that didn't work, yeah, pretty much just go to a tourniquet at that point. You could try more pressure, but I'll say this. I'm going to say this. This is something that another of our paramedic instructors says. Make your first attempt your best attempt. You shouldn't don't go into any intervention in an assessment and say, if this doesn't work, I'm going to do this. If you're worried about something not working, if it's bad enough for you to question whether it's going to be a success, then don't do it. Go ahead and do the next step. If you show up to somebody who's got massive bleeding and you look at it and you're like, all right, well, I know my first step is direct pressure, but that's a pretty gnarly bleed. It may not work. If my direct pressure doesn't work, then I'm going to do a tourniquet. Now, if you're thinking if that's your thought process, just do the tourniquet. Save the time because again, time is fluid and we can't put it back in as basics. So just yeah, if you feel like the direct pressure is not going to be enough, if there that doubts in your mind, then just go straight to the tourniquet. If you can justify it to me, to a court or whatever, if you can just say that, be like, at the time I saw the blood or the bleeding, it looked too profuse for direct pressure. I was worried about shock. Didn't have a paramedic on scene. I was operating with BLS only. I went straight to the straight to the tourniquet. You'll win that argument. So yeah, trust your gut, trust your training. Um, Excellent stuff. All right, your code for tonight is going to be BC. So Bravo Charlie 25. B is in Bravo. BC 25B. Anybody wants to write that? There it is. All right, awesome. All right, any questions? Before we end it, I just want to do a quick rundown of your assessments just to see kind of where you're at. Your assessments are broken down. First of all, you have your medical and your trauma. Within them, though, they run pretty much the same as far as, yes, we will have class next week. No, not Thursday. Remember, I gave you guys, if you look at your schedule, your holidays are off. But Tuesday we'll have a class. Um, your assessments are broken down into sections. You have your scene size up. You have your primary assessment. I want you to group all that other crap, your history taking and your vitals. That is your secondary assessment. And then you have your ongoing assessment. So first thing, learn the order of those. It's scene size up first, then primary, then secondary, then ongoing. Then start to learn what's within them. All right, because I'm going to start giving you guys scenarios where I say you show up and another EMT is already on scene. This is the last thing he did. What's your next step? Because you're going to get a lot of registry questions like that. And I just need you to know where you're at in your assessment based on what was done. It won't be hard. We'll start them. I'll make them easy at first, and then we'll just start kind of going from there. All right, guys, y'all have a great night, and I will see you on Tuesday.